Good morning. I'm Dr. Nitish here. I'm a radiologist from Sri Lakshmi Narayana Institute of Medical Science, Pondicherry. Today, we'll have a discussion on urinary system imaging. We are going to see simplest, easiest things for keeping in mind undergraduate students. Here, the coronal section CT scan reformatted image we are seeing. This is very easy to understand. Here we are able to see, I'm moving my cursor. You can have a look on this side. This is the right kidney. The renal sinus fat is a cortex, medulla, and then renal sinus fat. Here we are seeing ureter, right upper ureter. These are coronal images sections. So we do get to see partially things. So here this is the ureter, normal size. Now this is urinary bladder. This is uterus. This is what is urinary bladder. Now another side we are seeing on the left side. Here we get to see enlarged kidney. I'm going around the renal outline. I'm indicating renal outline. This is enlarged kidney. What we are seeing here is more enlarged kidney with dilated renal pelvis, where the renal sinus fat is obliterated. The ureter pelvic calyceal system is dilated. Calyces we are seeing here, they are dilated. Pelvis is dilated, then upper ureter. This is upper pelviureteric junction. This is upper ureter. When ureter is dilated down, here the arrow is indicating one dense area, dense near spherical area. The dense means on the whiter side, and as the density increases as per CT scan principle, the object will look denser. Like metal, bone are denser, fat is hypodense, and air is without any density. So here, what we are seeing spherical area, that's a ureteric calculus, which is causing obstruction. Because of obstruction of this calculus, here the urine is not able to pass down, and we are getting hydroureter. And the hydroureter, then the pelvis and the calyceal system also dilated. So it's a hydroureteronephrosis. And that in turn again causing back flow and back pressure changes actually. And the kidney is seen as enlarged with stagnated urine. Now, another changes are there, if you see here, related to that. We can see kidney, and here the right kidney, which is normal, non-obstructed. The fat around kidney is like the margins are sharp, and that is looking uniformly hypodense around the right kidney. Similarly, on the left kidney, suppose we see the border is little bit not so well defined, as well as around it there is some kind of a dense area is seen, cloudy. So this is called fat stranding or perinephric fat signal has increased. So perinephric fat stranding. So 3-4 things I'm again revising here. We are seeing obstructing ureteric calculus, which is causing back pressure changes, and proximal ureter is dilated. Here we can see on the right side ureter, which is normal. On the left side, the ureter is, if we compare, it is in multiplication dilated. The ureter is dilated, so the renal pelvic calyceal system is dilated. This is called hydroureteronephrosis. Secondly, changes to this, what we are getting to see is kidneys enlarged, perinephric fat stranding we have seen. So these are the three sequelae of obstructing renal calculus, obstructing ureteric calculus. The renal calculus, which has gone down to the ureter and it's obstructed. Now it is called ureteric calculus. We'll see the next image. So that was on the left side. Here we are getting to see obstruction on the right side, right ureteric region. So these are again coronal images. CT scan is a modality of choice to see the renal, ureteric, or bladder calculus. And in acute renal pain, this is an investigation of choice when we cannot see the calculus on ultrasound or there is ambiguity because of a lot of pain and gas in the intestine, as well as fat patient and corporate patient, or despite of trial, we are not getting to see the clinically it is suspected to be ureteric calculus. That in that case, it helps a lot, and it is like a gold standard. We can see the CT scan images. We get to see calculus almost to the tune of 100% times, and this ureteric calculus is seen here in the mid ureter, mid upper ureter. This is little bit elliptical, and which is causing back pressure changes so that upper ureter is dilated and it is hydroureter. Same patient, another section, we are seeing here like the coronal plane only, but like front and back. This is looks like this is little back side. We are vertebral column also we are seeing. Here we are getting to see not ureter in the same image, but here we are getting to see the renal pelvis, calacial system, and the kidney. Here, 2 points to be noted of here is that renal pelvic calacial system is enlarged on right side, as well as there are few other dense areas we are seeing foci. So these are calculi. These are called calacial calculi or renal calculi. So these are calculi, but they are not obstructing. They are non-obstructing calculi. So they are called non-obstructing calacial calculi. There are multiple. We are seeing here at 3 places. So again, we are summing up. This is like the same patient has obstructing calculus in the right upper mid ureter and non-obstructing multiple calculi, which are seen in the upper calyx, mid calyx, as well as lower calyx of the same kidney. The patient, because of obstruction of the ureter, is showing hydroureter as well as hydronephrosis changes. We go to the next image. Here again, here are the 2 sections we are seeing. One is coronal image, CT scan. Second is axial image. These are the axial. First, to just go through axial image. We are seeing here both the kidneys and other parts of abdomen at some point. Here the liver, intestine is a large bowel, and vertebra, muscles. This is subcutaneous fat. This is peritoneal fat. Again, I'm just mentioning it. This subcutaneous fat is a peritoneal fat. Now, kidneys we are seeing. So last image we saw this kidney was not having calcification within the parenchyma. That was within collection system. That was in the calicis or in the ureter we have seen. It could be in the collection system. It could be again still in the renal pelvis or in the bladder also. Now here, the calcification what we are seeing is within the renal parenchyma, but more towards medial region. So this is typical medullary calcinosis, what we call it. The kidneys are showing medullary region of kidney is showing dense calcification. So it is called medullary nephrocalcinosis. This what happens is renal tubules are dilated, ectatic because of their dilatation. Urine gets stagnated, and over the period, minerals start getting deposited. And when we see on CT scan, the typical images or CT scan on X-rays, we get to see the dense area involving medullary region of the kidney. This is by and large bilateral, more of a uniform things. And this is again, I'm concluding it by telling that this is medullary nephrocalcinosis. Here we are seeing all simple basic things. Again, the choice of images is done as per the frequency. What things again and again, what frequently and clinically important things, what we get to see for that. We are having discussion on that. So first we saw pediatric calculus, which is quite often emergency and quite frequently the patients come. Second, we saw medullary nephrocalcinosis. Third image, what we are seeing, a third slide, what we are seeing is here, both the kidneys are seen. In axial images, we are seeing both the kidneys are seen. But on the right side, there is some outpouching. That outpouching is adjacent to the renal cortex, outside coming. So that thing is well defined, almost oval to round or spherical to oval, and it has a relatively less density. So what we are seeing here is non-enhancing fluid density, well defined near spherical area. So this is renal simple cortical cyst. This is exophytic cyst additionally. So this is a cyst where the density will be near fluid, near water density, near water density, and kidney we saw that is again isodense, close to that only this density. And here we are seeing one more spherical area, which is partially exophytic and it's in cortical exophytic like that. So this is also spherical area. So here we are going to see little difference. What is the difference? So kidney, minimally hypodense to the kidney, we are seeing simple cortical cyst, and adjacent to there, again, a cortical region, spherical, well defined, but the density is higher. So this is simple cortical cyst, and second one is cortical cyst with hemorrhage, internal hemorrhage. So hemorrhagic renal cortical cyst. This is here we are coming back again. This first A slide, A image and B image. The difference is here IV contrast has been given, iodinated contrast, so that renal parenchyma is showing uniform enhancement. So this cortical cysts are known to have no contrast enhancement is there. No. So no enhancement is seen here, and the HU, unfilled unit density of the cyst, hasn't changed in plane or contrast. Now we are talking about second lesion, which is hemorrhagic cyst, as we have mentioned earlier. This hemorrhagic cyst also does not show any increase in the HU unit, that is density of it, post contrast. So that both the lesions are non-enhancing renal cortical cyst, and this is exophytic. This is like partially exophytic cortical cyst. This is the next slide. Here we are seeing both the kidneys, right kidney showing enlargement as well as multiple cystic lesions are there. But the left kidney has not a single cystic lesion here. So here almost the major part of the renal parenchyma is occupied by the multiple cysts. So it is cystic degeneration of the kidney is seen on the right side. Right kidney shows cystic degeneration, enlargement, cystic degeneration. Now we have seen ureteric calculus, renal calculus in calcius, then nephrocalcinosis, then simple renal cyst as well as hemorrhagic renal cyst. Now we'll go over to another very common pathology, and it can be easily diagnosed on CT scan or in modalities, using modalities. So one of the very common benign entity, which we get to see again and again. That's here. We'll describe first and then we'll come to the conclusion. These are the kidneys. This is the left kidney, the right kidney. We are seeing dense bone here. So as you spoke, the density is very high because of it is bony. Soft tissue is called isodense and fat is called hypodense. So here on the kidney, it's like lower pole of kidney, there is some mass, the well-defined margins. Little lobulations are seen. This is well-defined, lobulated mass seen along the lower pole of right kidney. Now let us characterize it further. So this muscle we always compare things with. So muscle is what we mention again and again is isodense. So this region particularly is much less density showing than the muscle and is somewhere close to peritoneal fat. So this is a region which is of somewhat fat density, close to fat density, and having within that some linear markings. So this is a very typical diagnosis of it. Is that is angiomyolipoma. Angiomyolipoma, when within angiomyolipoma comes in a different sizes as well as different kind of a patterns it follows. This is a single angiomyolipoma with adjacent fat is very clean, and though it's a relatively large lesion, it is not distorting kidney in a violent way. It must be long-standing angiomyolipoma. As sonography is used for abdominal evaluation very frequently, the most go-to modality is sonography, and patients come for sonography first. Actually, in very few emergencies and like a trauma, severe emergencies and all, CT scan patient is sent as a first choice, but most of the time, for abdominal interest region, sonography is the first modality of choice. Here we are seeing how this lesion is and how the normal structures are shown. This is the right kidney, as because of this is a liver here. We are seeing getting to see liver here. Then this is kidney. The lower part of the kidney is here. See here the cursors are shown here. This is like upper margin, is the lower margin. And here we are seeing kidney. The medulla is here somewhere, and renal sinus fat is seen here. So this is kidney. The shape is complete shape is kidney. So along with kidney, adjacent and involving its outer cortex is one different echogenicity. Here we are using on the CT scan consistently, we are using the term density. In ultrasound, we are using the term echogenicity. So here we are seeing large relatively, not like a kidney intensity. This is some abnormal intensity region seen involving the cortex of kidney, and adjacent area it is little bit of exophytic nature also. So what we are seeing here, what kind of a pattern and what kind of a echogenicity it is signal it is showing. So this renal parenchyma is relatively iso to hypo. Liver is also iso. So what we are discussing in the CT scan, fat will be hypodense, but on ultrasound, the fat will be hyperintense. It shows more signal return. Okay. So here we are seeing more signal than the kidney. There is a hyperintense lobular mass, a large mass we are seeing here. So this intensity and this kind of echoes will suggest us it's a fat containing mass. So again, a case of angiomyolipoma on ultrasound. So on ultrasound, it is seen differently. On CT scan, it was hypodense or little darker side of the kidney than the renal parenchyma. On ultrasound, exactly opposite to it. The renal parenchyma is isodense, or we can say in the general term, little darker, but the region angiomyolipoma is appearing hyperdense, hyperintense. So hyperechoic. So it is like showing more signals. So it is like echoes are seeing more. So it's a hyperechoic. This is a hyperechoic lesion involving renal parenchyma. So this is angiomyolipoma. Now again, we are seeing kidney. Both the images are, one is of CT scan axial cuts, one is plain or non-contrast study, what we call it in the short form, NECT, non-enhanced CT, and second is after giving contrast, what we call it again, it is like enhancing CT, contrast enhancing CT. So it is called CECT, contrast enhanced CT scan. So what we get to see here is on the lateral margin, along the lateral margin of the kidney, there is a lesion, abnormal lesion is seen. Both the images show abnormal lesion. So that is characterized. Why we are angiomyolipoma benign, but why it is important? Because to rule out it is angiomyolipoma, to come to the diagnosis so that it is not a malignancy. It is not a cancer. You see that here, it is important to diagnose it if suppose if it is angiomyolipoma as it is. So here we are seeing a region. Again, characteristic thing on CT scan is it is showing area of relatively hypodense area is seen. So that is close to fat and not like muscle or renal parenchyma. So here we are getting to see close to fat heterogeneous area along the lateral margin of left kidney. Now we are seeing the contrast. Here it is seen much better actually, because as kidney showing enhancement and our angiomyolipoma is not showing any enhancement, or minimally subtly enhancement is seen at the periphery, but most of it is well demarcated on contrast. What we are getting to see is the lesion is very well defined, well marginated lesion with non-enhancing lesion with near close to fat density. So this is again a case of angiomyolipoma. We'll go to the next image. We're talking about angiomyolipoma. Most of them are single. Now here there are multiple areas of smear. This is again a CT scan image. This CT scan image is a coronal cut. Post contrast thin coronal cut it is. What we are getting to see is multiple, almost innumerable, well defined, close to fat intensity. So these lesions are there. So these are multiple angiomyolipoma. So there are certain syndromes are there. We'll discuss further. One image is there. Here again, multiple angiomyolipomas are there with cortex as well as within the cortex. Some are extruding. Now here we are seeing angiomyolipoma again is important when it is more than 4 centimeter in diameter. Why it is important? Because it is rich in vascularity and there is a tendency after 4 centimeter to bleed. So here again we are seeing the region here is a large angiomyolipoma, but here there is a change. This is fat density. Contrast is given in this patient. All images are contrast enhanced images. How to confirm is the aorta is showing dense signal because of iodinated contrast. And their vessels are also seen, they are showing dense signal. So now we are seeing here large lesion is there. Along with that, there is some isotope hyperdense area within the renal fossa. So this is the case of secondary bleed to angiomyolipoma. There is hemorrhage and it is causing massive hemorrhage, actually severe hemorrhage, and this is the picture of it. So this is a complicated case of angiomyolipoma. Here again, I would like to mention two very, very important points. One is angiomyolipoma more than 4 centimeters are more having more tendency to bleed. So they are categorized as more than 4 centimeters and they are important because of they may bleed further future. So that is one point. Above 4 centimeters is important. Second point is the angiomyolipomas, those which are more than 4 centimeters, are electively operated on. Okay, embolized or that is given a treatment because they may bleed further. So embolization is done and the risk of bleeding is minimized or reduced. So here we are seeing large angiomyolipoma with severe bleed and traversing one vessel is their blood vessel, which is shown by yellow arrow. Here the again same thing, hemorrhage has happened to angiomyolipoma, renal parenchyma enhancing normal parenchyma we are seeing here, but the partially kidney is little bit distorted on anterior side because of angiomyolipoma is there on anterior region. Addition to that, there is large hemorrhage. This is the case of again angiomyolipoma, but the investigation, the study is DSA. Here I have purposely intentionally kept this slide because same patient it is both the slides. Here what we are seeing is somewhat this is catheter or angio-renal artery is through DSA technique, digital substruction angiography technique. What we are selectively seeing enhancement in the kidney is a large angiomyolipoma having rich vasculature, and then abnormal vessels are like showing ectatic as well as irregular pattern and little cloudy kind of appearances here. And this is angiomyolipoma. It's such a large angiomyolipoma. How they embolize and then how it looks after embolization. So this is embolized here. After embolization, this is after embolization. Here the heading is also written in yellow. After embolization, that part which got embolized is no more seen on angio, digital substruction angio. And here what we are getting to see is normal kidney with a normal pattern. So this is large angiomyolipoma before embolization and after embolization. So that again, we are coming back to angiomyolipoma only, but then these are like multiple, or we can say it innumerable, fat density, well-defined regions are seen. Multiple small fat density, well-defined regions seen in both kidneys. So what is happening here? These are like pure fat lesions. This is such kind of appearance is there in some syndromes I was telling, and here the syndrome is tuberous sclerosis gives such kind of images. Okay. Now, additional finding is there shown by arrow. This is like almost exophytic angiomyolipoma, but here there is a change. This is larger and more not like a fat density, but it is showing isodense or heterogeneous density. So this is early change of angiomyolipoma towards aggressive nature, and this is early. This is probably early malignancy formation in angiomyolipoma. Here we are seeing oncocytoma. We will go a little faster. Here we are seeing large mass pit showing some kind of enhancement not as much as renal cortex, but slightly mildly enhancing area is seen. Centrally, there is a scar. So this is typical identification type of markers and radiating kind of a thing. This is oncocytoma. Typically, we go next image. Here again, very well defined renal mass, which is displacing the renal parenchymal internal things. And this lesion is very well defined, centrally non-enhancing, and the pattern is little bit radiating type of pattern, where from central non-enhancing area, the radiating pattern is seen towards outer direction. So this is central scar, what we call it, and this lymphocytoma. Another image, same patient, okay, actually, another image. Here we are seeing large lobulated lesion arising from the left kidney. So this is RCC, and which is showing deficient restriction here. Again, another image of RCC. Now here we are same patient, different level of cut, coronal cut it is. What we are seeing here is this is first and foremost, this is MRI image, coronal section, the large renal mass with thrombus seen in the renal vein. So RCCs are prone to cause, renal cell carcinoma are prone to cause renal vein thrombosis, which can go extend to the IVC. According to its extension, the treatment is planned, and so the grading is there. And here we are seeing ultrasound image. We are trying to see pathologies in different modalities. We saw CT scan of for RCC patient, renal cell carcinoma. Then we saw MRI image. Now here we are seeing sonography image. What we are seeing here is that this is normal upper pole of the kidney, and on the lower side, lower half of the kidney is engulfed by a large mass, which is heterogeneous and almost distorting complete anatomy of lower pole, as well as it is invading into collection system. Probably it is invading at the pelvic junction or adjacent to it, so that there is some amount of obstruction to be there that is leading to hydronephrosis. What we are seeing here dark is this is the calyceal region, and this is renal pelvis. So this is enlarged renal pelvic calyceal system we are seeing because of obstruction secondary to neoplastic lesion of kidney along the lower pole, and this was a case of renal cell carcinoma. We go a little faster. Here, a large lesion lobulated, a case of renal cell carcinoma. The study is MRI. This is fat suppressed MRI actually, and ketogenic fat suppressed MRI. That's that MRI. The lesion is seen very well. Central necrotic area is seen, which is showing fluid signal. Here we can see renal pelvis as a hyperintestine. Here CSF is seen as hyperintestine fluid. Here in the intestine, fluid is seen as a hyperintestine. Same time, I'm just coming back to here. This is the central area, which is showing fluid signal because of central necrosis. Again, a large lesion, which is malignant renal cell carcinoma. Here, again, carcinoma, renal carcinoma. This is the varieties papillary type renal carcinoma. Here, this is another entity. Here we are seeing both the kidneys are showing enlargement. By and large, kidneys are less than three vertebral, first three to 3.5 lumbar vertebra um, is a maximum size of kidney. This is somewhat crossing almost 4 vertebral length. Here, both the kidneys are enlarged and showing peripheral enhancement as well as a little bit indefined area, thickening and all. So, this is the case of lymphoma. Lymphoma is involving kidneys. On PET CT, what we are getting to see is a very strong uptake of isotope. Both kidneys are involved as well as multiple lymph nodes. Can we see here? A little bit focus view. It's very clear. This is aorta. This is vena cava. This is vertebra. So they are not showing any kind of a hotness, what we call it in nuclear studies. So they are like iso dense, but then here the both kidneys uniformly almost showing excessive uptake of isotope, as well as the metastatic nodes are also identified here by the both arrows. These are the metastatic nodes. This is the case of lymphoma. Now we'll see here. And here the first patient came with a small hypodense area within the anterolateral region of cortex, and then the remaining cortex was not involved. Only anterolateral region of the cortex. This is region here. Within 6 months of it, what we get to see about the same patient is that area is enlarged a lot, and it is almost occupying more than 80-90% of the renal parenchyma at that level. So this is the case of renal cell carcinoma, aggressive renal cell carcinoma. Here, very important thing again is like when there is carcinoma. Here we are seeing few findings. Kidneys have multiple hypodense areas, non-enhancing areas, abnormal areas, as well as liver also has multiple abnormal areas. Hypodense, non-enhancing areas are seen, and the margins are not well defined, so that goes in favor of malignant regions. And multiplicity also one of the various morphologies, and goes in favor of malignancy. Here we are seeing renal cell carcinoma metastasizing to the liver, and one extra additional finding is there shown by the yellow arrow, that is left renal vein showing intraluminal non-enhancing area, that's a thrombus. This is just to get fused lower poles of the kidney. This is horseshoe kidney, and mid-sagittal section shows there is band in between the two kidneys. That's called sometimes isthmus. Here again, we are seeing horseshoe kidney. This is the kidney. This is almost in the pelvis, and little bit distorted kidney. This kind of a kidney, ectopic kidneys, they are joined together. So these are like all like a pancake kidneys. What we are seeing dense here is, because of contrast, this is a case of a renal transplant. Here I would like to mention one point additional. Transplanted kidneys are not in the renal fossa, but they are inside, almost in the pelvis. They're much distally located, and their vascular supply is from iliac veins rather than aorta. So here the right iliac artery as well as the vein has given access to renal artery and vein. So this is more close to the pelvis, this particular kidney. This is a pubic bone, actually, superior pubic ramus. Just very close to that is transplanted kidneys. What we are seeing here is, in contrast study, kidneys showing normal cortical enhancement, but shape is a little bit altered. Perirenal region is showing some isodense non-enhancing spherical area. That area is due to, in a transplant case, biopsy was operated, two-cut biopsy was operated to see the histopathological to do the histopathological study of renal parenchyma. Uh, so whether the graft is rejected or accepted, or what kind of whether necrotic changes are there, I mean, setting up or what early changes. So for that reason, biopsy was done, and what we get to see here is post biopsy. There is a large lymphoma. Again, ectopic kidney on the right side. It has actually dual system, collection system, and here what would like to mention is uh, the ureter lower is showing some spillage of contrast because of there is tear in the ureter. Here, another entity we have kept here is for the discussion is this. The insertion of the ureter is not in the normal region, where actually normal ureter will be posterior superior region of the bladder. We'll have insertion at uretropelvic junction. But in this case, particularly, here we are seeing ureter is much posteriorly and down. Eventually, it was seen that it is getting drained in urethra. So the patient had incontinence since the beginning. For life, the patient was having incontinence, dribbling of the urine. Here we can see the image. We can see here the ureter rather than somewhere here inserting, it is getting all along down, and insertion is seen post membranous urethra, where like dilated almost bulbar urethra region, it is showing the insertion. So incontinence or dribbling of urine will be seen in these patients. Here there is a mass, neoplastic mass in the right kidney, lower pole. We are seeing this is a retrograde ureterography. So whereupon ureter is accessed through the bladder and contrast is inserted. So we are getting to see lower calyces along the mass showing irregular borders, and because of invasion of the pathological lesion into the calyceal system of calyces and pelvis, that region is showing ill-defined margins as well as the amount of excreted urine shown here, that is very less. This is the neoplastic entity. We'll go a little faster. This is again urothelial carcinoma of ureter. Earlier it is too commonly called transitional cell carcinoma. So here we are seeing soft tissue mass and stagnated urine. This lesion is showing on post contrast some enhancement. So near total blockage of or complete blockage of the mid-lower ureter is seen here. So that hydronephrosis. This is secondary to urothelial malignancy, urothelial carcinoma. We are seeing another case of urothelial carcinoma. Here we are seeing partial obstruction. The mass is causing the presentic denser area is seen. That is the whiter denser area is representing urine actually, and in the ureter. It's like since there is a partial obstruction, some amount of urine is passing through it, and just toward the center of the crescent, there is a soft tissue mass, and that is what is important this diagnostic thing, that is urothelial carcinoma of ureter. We'll go further, same images are there. Here, soft tissue lesion is seen on ultrasound. This is actually ultrasound. This is done intracavitated ultrasound. On that, on the bladder, along the wall, there is a intraluminal hanging soft tissue mass. This was again urothelial carcinoma. This is ultrasound image. This is MRI image. Whereupon we are seeing intraluminal large mass of tissue mass. Again, multiple things are here. That first image we are seeing wall is still intact and normal, not invaded or not crossed. So next image, what we are seeing is wall is thickened. The lesion, intraluminal bladder lesion, causing wall thickness as well as adjacent area also it is going to be influencing or invading. Here on contrast study, we are seeing enhancement of the region. This is on diffusion weighted study. Again, urinary bladder urothelial carcinoma image is a large lesion, almost going out of the adjacent fat it is invading, as well as it is causing sigmoid colon wall is inseparable. There is a fat plane in between sigmoid colon and the lesion is obliterated. So grading changes to that and the treatment line also changes. Here ultrasound and MRI images of prostate are kept henceforth. This is MRI image. This is a lesion in prostate. The peripheral zone. Central zone appears normal. Here peripheral zone lesion is there. Here is a large lesion. Central zone and transitional zone, it is almost engulfing. Another case of prostate malignancy. Now, here we have kept this image, but clearly this is very commonly done. Transrectal biopsy. With a biopsy shooting gun, here it is shown. What is most important in biopsy, what we should be careful about, one single important thing is whether the sample is taken from the right region. So how to see that right regions? Definitely there is imaging modalities coming force, whereupon on ultrasound or CT scan or MRI, we get to see the abnormal area, and that area we select and then take the biopsy. These are the beautiful MRI images, whereupon biopsy is taken from the nodule, abnormal nodule. So this is the images, MRI guided prostate biopsy through throughput gun, actually, biopsy gun method. It's called. This is the image of stricture to the urethra. This is again retrograde urethrogram. Here we are seeing membranous urethra, which is thin, almost negligibly seen. Then bulbar urethra and adjacent to bulbar urethra, anterior to bulbar urethra, we are getting to see a stricture. This image again on delayed image of IVP, what we are getting to see is multiple filling defect, well-defined multiple filling defects are seen all along from renal pelvis, renal calyces to ureter, even in the bladder. On the right side, there is hydronephrosis, probably because of the very like significantly dilated right ureter is seen, as well as it is shown as a delayed contrast or not so dense contrast. This is a standing column ureter is on the right side. And here, probably at the junction of ureter and bladder, there is a neoplastic lesion which is obstructing the urine so that hydroureteronephrosis is there further. Here, you are seeing multiple hypodense areas. They are actually multiple myeloma lesions. We are done with. Thank you very much. Vanakkam.